Hello. Hello, I hope everybody is doing well. This PowerPoint is going to cover group beta strep, premature rupture of membranes, and dystocia. Probably the two of the more important of this PowerPoint would be group beta strep and premature rupture of membrane. When we talk about group beta strep infections in newborns, we're talking about the early onset disease that occurs in the first week of life. This early onset can cause sepsis, pneumonia, and sometimes meningitis of newborns. It's interesting because when I first began working as a nurse, I never knew this was causing a problem in newborns. And we really didn't do anything preventive-wise. And there's a few babies, though, that got very sick, and actually a few babies that died. So now we don't want any bad outcomes. So we actually do preventive measures to prevent babies from getting sick. Now, group beta strep is actually a normal bacteria in some women down in the genital area, both the vaginal and rectum area. For them, probably in about 25, maybe a little bit greater % of women in our population, it's a normal bacteria and it causes no harm. They can go into labor and deliver a baby and it will cause no harm. But there are some moms that carry this, and when they deliver the babies, some of the babies get sick and end up with sepsis, pneumonia, and meningitis. And therefore, we want to identify any woman in that 25 or greater % range that carries GBS and do some preventive measures to prevent their baby from getting sick. In the United States, it is the leading cause of meningitis and sepsis in a newborn's first week of life. 25% or greater, now the stats will show, of pregnant women will actually carry group B strep in the rectum or vagina. A woman who will test positive and gets antibiotics in labor has only a 1 in 4,000 chance of delivering a baby with disease, a 1 in 200 chance if she doesn't receive antibiotics. So you can see that a 1 in 200 versus a 1 in 4,000 chance is huge. Some risk factors for somebody with GBS is anybody that delivers a premature baby, and we learned that's before 37 weeks gestation, a prolonged rupture of membrane greater than 18 hours, if mom gets a fever during labor, or if mom has had a previous infant with GBS infection, or if she has GBS during this pregnancy, and even demographic, a young age or African American or more prone for being a GBS risk factor. So what are the guidelines? What do we do to prevent this on our infants? We screen women at 35 to 37 weeks with the vaginal and rectal culture. So we take a screen and we swab the vaginal area and go down to the rectal area. And we send that to the lab. And the lab will usually have that culture back in a couple of days. If it's positive, we let the patient know and we will treat. And if they're negative, they have nothing to worry about. Now, sometimes if you tell a woman she's got group beta strep positive, they think it might be an STI, and you need to reassure them that it's not. It's a normal bacteria in some women, but because we're going to take precautions and so that the baby doesn't get sick, because there are chances that sometimes babies will get sick. Now, we treat any previous history of an infant with GBS disease or any woman with a current GBS status. Now, if somebody is scheduled for a C-section and they're GBS positive, we only treat if they have rupture of membranes or they're laboring before their scheduled C-section. That's the only time we will treat them. If a patient does not have a culture when they come in to deliver, we will treat if they're at high risk, which we talked about earlier, less than 37 weeks, prolonged rupture of membrane equaling greater than 18 hours, a maternal temp of 100.4 or greater. We use a sterile swab to collect the sample from the vaginal to the rectal area, and we send that to lab. Normally we do it around 35 to 37 weeks gestation at their normal prenatal visit. Again, we do it as a preventive measure. Newborns are at increased risk for group B strep infection if their mother tests positive during pregnancy. We can prevent newborns from this risk by giving a pregnant woman antibiotics IV during labor. Antibiotics only be given during labor, not before, because the bacteria grows so quickly, so it doesn't really make sense to give them antibiotics early. Usually give IV penicillin, which is preferred, but there are some hospitals that have formularies that may give ampicillin. Usually with a loading dose, with penicillin, we would get 6 million units. And then after that, about every 4 hours, we would give units until delivery. This 4-hour limit is important because for a patient's baby to be protected, it would need the loading dose and at least one dose afterward to be effective. So it would need at least the first 2 doses. Remember, we're treating the early onset, not the late onset GBS. For the future, we're working on a group B strep vaccination, but to date, receiving antibiotics IV is the only proven strategy to protect a baby from early onset group B strep disease. Do you have any questions about group B strep? Write them down. And we know it's a big because on those bar sheets that we use for clinical, they always ask if mom is group B strep, positive or negative. Again, we test them at between 35 and 37 weeks to get that information. The next thing we're going to talk about is premature rupture of membranes. We've already talked about rupture of membranes when the water breaks. But sometimes when we talk about premature rupture of membranes, we're speaking about when the membranes rupture, the water breaks, prior to the woman being in labor. So spontaneous rupture of amniotic membranes before the onset labor is the definition of PROM, or premature rupture of membranes. It's responsible for 1/3 of all preterm births. And its common maternal complication of PROM is chorioitis, which is just an infection of the lining of the uterus, which can be very, very serious for both mom and baby. You can see somebody with polyhydramnios or too much amniotic fluid here would be more susceptible for premature rupture of membranes because it's like a full balloon. It's easier to pop versus a balloon that's not inflated as much. Some of the complications that can arise with premature rupture of membranes other than infection would be if the head's not well down into the canal and the water breaks before the head is engaged, the cord could slip through and called a cord prolapse. And then when the head does come down, it sits right on the cord and decreases the amount of blood and oxygen to the baby, which could result in fetal demise. And I think we talked about that earlier, how if a cord prolapse was there and we couldn't get the cord back up, we would have to hold the babies up and C-section the mom for an optimal result or outcome. Some of the nursing implications for somebody who ruptured premature is we're always concerned with infection. The more we check her on the vaginal area, the more chance she is of infection. Therefore, we try to limit vag exams or cervical exams, whatever you want to call them, or anything in the vaginal area to decrease the amount of infection. We also can monitor infection by checking their WBCs. Remember, any foul-smelling vaginal charge would be indicate possible infection, as long as a fever. When a mom does have a fetus, her uterus may become very tender. And we also talked about, when we talked about fetal heart tones, that tachycardia can occur with mom getting an infection. Any questions on that? You can and we can class. We already talked about shoulder dystocia, which can occur a lot of times with a large baby macrosomia, which if you've already listened to the diabetes lecture, we talked about 50% of diabetics have macrosomia. And shoulder dystocia is when the head is, the baby is large, but what happens is the shoulders get stuck. And usually the baby's head is kind of stuck in there, and baby will be lacking oxygen to the brain. Usually the nurse will put some suprapubic pressure there as the doctor does the maneuvers to get the baby out. Very, very stressful situation at the time of birth. So the definition of shoulder dystocia is failure of the delivery of the fetal shoulders, whether they are anterior, posterior, or both fetal shoulders. So basically, the shoulders get stuck. This delivery requires additional obstetric maneuvers following failure of gentle downward traction on the fetal head to effect the delivery of the shoulder. So basically, the doctor is going to do some maneuvers. The nurse is going to give suprapubic pressure, and hopefully that works. Now that's shoulder dystocia, but we also have dystocia in labor, which basically the definition for that is a long, difficult, or abnormal labor occurring in 8 to 11% of all births and a primary cause of cesarean birth. So basically, dystocia can be caused by the dysfunctional labor, which is the power, an alteration in pelvic structure, which is the passageway. So if you have a dysfunctional labor pattern, you're going to have an interruption in your labor or dystocia. If the pelvic structure is too narrow, the baby can't come. The passenger baby cause, if it's too big. Maternal positioning, maybe you're not moving the position of the patient enough and she's lying flat on her back, would cause some dystocia. Or the cycle response to labor, which is she empowered to do it? And remember, we talked about the 5 E's before. So let's talk a little bit about the powers. What is dysfunctional labor when we talk about the powers? It could be two things. It could be hypertonic uterine dysfunction or hypotonic uterine dysfunction. Or it could be the secondary powers, which is the pushing that is ineffective. Hypotonic uterine dysfunction. Oftentimes we have an anxious first-time mother. She's having contractions. She can't sleep. They're painful, but they're ineffective. And her cervix is not changing. Usually this occurs in the latent phase or the first stage of labor, latent phase in the first stage of labor. The mom becomes exhausted and lost of control with her lack of progress. She comes into triage. She's not in labor, but she's totally exhausted. Usually when this occurs, a lot of times we'll give them something to relax them, something maybe even to sleep, so that when she wakes up and goes into labor, she'll be well rested. Hypouterine dysfunction is when somebody comes into labor, they're making progress, and then around 5 centimeters, all of a sudden their contractions become weak or they may even stop. Sometimes this may be a sign that the baby's head is too big for the pelvic, which is CPD, cephalopelvic dysportion, and that just means the baby's head is too big for the birth canal. But also sometimes maybe we just need to get the mom moving to augment the labor, get her up in an upright position, or maybe augment her with some Pitocin. And if we do that, sometimes we may want to put in an intrauterine pressure catheter to measure those contractions to see if they actually are good enough, and she may need to be augmented with Pitocin. And also this IUPC helps us in determining how much Pitocin she needs to establish good contractions. Dysfunctional labor. If you have any questions on dysfunctional labor, again, please write them down. Refer to your book to get a better understanding or other resources. And if you have any questions, you can ask them during our class time or just email me. Thank you.